Hello, friends. Have you ever gone to the hospital and then you get the bill like months later? Like, how hard is it to write up an invoice and mail it to you? As it turns out, very hard. Let's tell the story of how a medical bill happens. Let's imagine somebody who goes to the hospital. Let's call her Barbara. She's 63 years old and she has difficulty breathing. She gets out of breath even walking to the bathroom, which is new for her over the past week. Before that, she was in nearly perfect health. She's worried about what this means and is afraid that it will continue to get worse, so she goes to the emergency room. The triage nurse takes some vitals and some other basic info in order to figure out how urgently she needs to be seen. When the ER doc sees her, based on her history, physical, and an x-ray, she diagnoses her with pneumonia. She also decides that Barbara looks bad enough that she needs to be treated in the hospital. Barbara spends a few days in the hospital where she receives IV antibiotics. Then she's well enough, so she goes home. Now, her caregivers have been writing in the electronic health record, or EHR. Now that Barbara has been discharged, that is forwarded to a coder, not a computer coder, but a medical coder. First, they'll take the symptoms and code them via the ICD-10 system. Then they'll take the other procedures, medicines, durable medical equipment, and other services, and code them via the CPT system. Each CPT code has a cost associated with it, and some of them have modifiers. Here, for example, an IV infusion is modified with the drug code for levofloxacin. The CPT code determined the initial bill, and the ICD-10 codes justify the charges. That information gets sent to billers who format the information and send it off to the clearinghouse, who in turn reformats the information according to the insurance company's preferences, and then sends it to the insurance company. Clearinghouses used to be physical locations, but in the electronic age they are mostly digital spaces. Next, the bill arrives in front of the insurance adjuster. Their job is to go over the bill with a fine-tooth comb to look for any errors. Maybe the hospital stay portion of the bill was coded with the wrong level of acuity. If they can, the adjuster will reject the entire bill outright. Then it goes back to the biller and coder, who can either edit the bill to fix any errors, or dump the entire thing on the patient. They tend to do whichever is more likely to result in payment, which, fortunately, tends to be fixing errors. But not always. If it isn't rejected, the prices for each CPT code gets adjusted. Maybe the hospital bill is $100 for the x-ray, but the insurance company only allows the hospital to bill $30. The missing $70 doesn't get forwarded to the patient, the hospital just doesn't receive that portion of the bill. I'll talk about why the insurance company gets to decide that in a moment. Assuming it all goes through, the insurance company sends an explanation of benefits, or EOB, to both Barbara and the hospital. They can also send a check to the hospital. The EOB spells out how much the hospital is to receive from insurance company and how much they can bill Barbara for. So let's draw this triangle of Barbara, the hospital, and her insurance company. She isn't old enough for Medicare yet, so she has a private insurer through her work. Maybe it's Aetna, Anthem Blue Cross Blue Shield, or United Healthcare. If she didn't get health insurance through her employer, maybe because she works for a small business or works 2 part-time jobs, she might try to get Medicaid, or a marketplace plan, which may be an option if her state expanded Medicaid. If she was connected to the military, she might have TRICARE. The relationship between the hospital and Barbara is such that she receives care in exchange for paying her out-of-pocket expenses. There is a contract obliging her to do that, and if she doesn't, her bill can be sent to collections. There is also a contract between the hospital and the insurance company. If there isn't a contract, then it's considered out-of-network, and things get a little bit more complicated. Basically, things get more expensive for Barbara if she ends up out-of-network. The contract between the insurance company and the hospital determines which services are billable and for how much, and the minimum price for procedures for uninsured individuals, which serves to artificially inflate the value of having insurance. The price for each CPT code is theoretically the result of negotiations, but pretty much Medicare sets the prices for each CPT code, and then private insurers take that amount and make it slightly more. Medicaid pays significantly less. There's also a contract between the insurance company and Barbara. It determines what kind of things are covered, as well as copay, co-insurance, deductible, and premium. Here we must define some terms. The premium is how much Barbara pays to have insurance. This is paid, in her case, by her employer. This can be made many thousands of dollars per year. Next is her deductible, which may be anywhere from $500 to $5,000. In general, the higher the deductible, the lower the premium. The deductible is how much you have to pay out of pocket each year before the insurance company pays anything. The copay is a fixed fee you pay for every interaction with the healthcare system, even if you've already met your deductible. Maybe the copay is $20 for a primary care visit, $50 for a specialist visit, or $100 for an emergency room visit. Coinsurance is a percentage of the total bill, and not every plan has this. So if your coinsurance is 20%, then you have to pay 20% of the hospital visit. There are other complexities I brushed over, like how surgeon time is billed separate from surgery, but I'm not trying to teach you how to bill in code. Now let's go over this system and discuss some problems with it. Let's start with the billers, coders, and adjusters. These are individuals who are often not educated beyond high school, yet the job requires some training, so they do receive decent wages. The billers and coders work for the hospital, so they are encouraged to send bills that result in payment. The adjusters work for the insurance companies, so they are encouraged to reject bills such that they do not result in payment. Sometimes there is a bill that bounces back and forth between biller and adjuster, as they both try to make money for their organization they work for. Now, these are real individuals receiving money for their work. Where does that money come from? Patients and taxpayers, ultimately, who contribute to this silent battle between clerical staff of opposing businesses via out-of-pocket costs, tax-funded government subsidies, and insurance premiums. These are individuals who are not involved in patient care whatsoever, mind you. Of course, that also means if the U.S. healthcare system were to be reformed, to be made actually affordable, these are all people who would lose their jobs. But the consequences of unaffordable healthcare are even starting to impact insured individuals. If Barbara can't afford a bill, she has a number of options. She can contact the hospital to request financial assistance, but that probably won't work if she has private insurance. Or the hospital will send the bill to a collection agency, and they'll do the work of collecting on it. Barbara may be able to set up a payment plan with a collection agency, but if she can't do even that, then she may have to declare bankruptcy, or else endure the unending harassment from the collection agency. Medical bills in the United States are the #1 cause of bankruptcy. If she does pay, though, then the process is over, assuming that nothing got duplicated and the coders, billers, and adjusters did a good job of dotting their I's. Now, if she did not have insurance, she wouldn't have an adjuster with an insurance company to negotiate a lower price for her. In fact, the insurance company's contract mandate not only how much they pay the hospital, but also the minimum price the hospital can charge individuals without insurance. They do this to artificially inflate the value of the services they provide for their policyholders. For that reason, the cost of any given procedure for a patient with insurance who has not met their deductible is less than the cost for a patient who does not have insurance at all. Now, the uninsured patient who has an unaffordable bill can appeal for help from the hospital, but they have to know how to do that. They have to know that they can do that, and that they have to do it in a certain time limit. Even after the time limit, they can request a discount from the billing department. The billing department may have mercy and reduce the prices down to what Medicare would cover, but then again they might not. A few hospitals in poor areas will even own their own collection agencies, with which they bring in uninsured individuals to court to force payment, even if it means garnished wages. There are other problems with the system as it stands. Hospitals get paid to do more, not to make people healthier. One attempt at reform is called an accountable care organization, where instead of billing cardiac catheterization, medical adjustment, doctor time, pills, etc., a whole laundry list, the hospital bills for heart failure management. They take the average amount that heart failure costs the hospital and pays that amount. Saves on paperwork. You get bonuses for treating patients well and penalties for treating them poorly. This is an oversimplification, and it has its own pluses and minuses as a system. Another fix is called direct primary care. If you cut out the middleman, you can greatly reduce inefficiency. Direct primary care physicians bill patients around $70 a month, and for that, patients can call, text, or come in for a visit whenever they want. It costs a lot less than insurance or for paying for each visit out of pocket, but it doesn't cover hospital care or specialty care. But going back to traditional billing, one of the big problems with the whole situation is that if the patient asks, how much will it cost to do X, nobody knows. Take Barbara. I hypothetically gave her levofloxacin, which costs around $10. If she needed vancomycin for a resistant strain of bacteria, which is something the doc wouldn't know until after some testing, it would cost 10 times as much. You also don't know how long she needs to spend in the hospital until she's gotten better. So if she called the ER before going to ask, how much will it cost to fix my shortness of breath, only God would know. Like, if I want to know how much it will cost for a doctor to help my knee pain, they can't answer me. It depends. Maybe I have one short visit which costs like $150, and the doctor tells me to take an ibuprofen, and that works. Then it only costs $150. But maybe I need an x-ray, and then a joint aspiration, then some antibiotics, and eventually a joint replacement. The cost will be a lot more. And if you just take the joint replacement, which is an elective procedure, you don't know whether or not you'll get staph epidermidis infection that needs expensive antibiotics. You don't know how long it will last, the replaced joint, and you don't know how much physical therapy you need to recover. You don't know if the surgeon will finish quickly or if it will take a while, and they bill by the hour. The doctors and nurses often don't know about the billing process. Even if they do, they don't know the specific prices. A biller can maybe tell you the typical range of what patients pay, but that's as good as it gets. So for a clinic I worked for, I could tell you that a cost of a visit that involves an injection could cost between $200 and $600, probably close to $350. But I can't even guess how much you have to pay before you start to feel better. Maybe one injection is enough. Maybe you never get better despite 20 injections. People say hospitals should tell patients how much things cost. That way patients can make reasonable financial decisions. In a way, hospitals do. If you search hard enough, you can find a list of CPT codes and their prices. That's supposed to be publicly available information. If the hospital is an accountable care organization, you can find the price for a select few reasons for hospitalization. But that doesn't tell you what you want to know. If I seek care here, how much less money will I have in the end? In order to fix what seems like a simple problem, lack of price transparency, you would need to completely change the way billing happens. Until then, the best we can hope for is rough estimates. And if the point of price transparency is to encourage price-reducing competition between hospitals, then you know hospitals will do what they can to underestimate prices, changing the answer to the question, how much money will I lose, from, I don't know, to what is probably a deception. Anyway, I hope that was educational.